this presentation has two halves. The one is on predominantly focused on residency/fellowship. I understand that both ONTPD and some chiefs are here on the call, so I will finish that, and then if there is interest, we will talk about the financial and non-economic implications of a separate department at a later time. So, okay, here we go. So, two disclosures, as Brooke mentioned, this is not a talk about oxygen, this is a talk about money and time. So there is definite difference between the two. And I don't have any financial background or training. Of all the positions in neonatology, I tried being a program director for 4 months. I failed and I backed off. So that's one job I have not been able to do, although I was an associate program director with Dr. Rita Ryan for 6 years. And I do understand the implications of running a fellowship. The objectives for this presentation include brief discussion about the current state of neonatology fellowship, recruitment issues, etc., the effect of reduced interest in pediatrics, effect of limited rotation time in the NICU, and pros and cons of a 2-year fellowship, and pros and cons of a 4 to 5-year neonatal critical care residency. And I'll spend some time that some of you might have already heard me talk about long-term financial and work hour implications for academic neonatology and the consequences of that. And feel free to interrupt me, raise your hand, or tell me to stop, because some of these slides are include some complex financial information, and I'm happy to go over it in a greater detail if needed. So you are a group of people who know a lot more about this than I do, and among the pediatric chairs, there was a lot of concern about NRMP match this year, and there's a bit of a sigh of relief that numbers did not look as bad as we were anticipating. As you see here, compared to the last year's rate, when it had declined from 97.1 to 91.8% fill rate, this year pediatrics offered a bit more positions, 54 more than last year, and filled 95.3%, which is better than last year. So things look at least a little brighter on the pediatric side compared to last year, but there are still lots of concerns about medical students entering into pediatrics. What about neonatal medicine fellowship? This is 2024 match data from the NRMP website. At least on the initial match, 24.3% of the programs were unfilled. And for the first time that I can recall, some of you might know this better, I saw the positions filled, this number go below 90% for the first time that I can recall. So 12.6% positions were unfilled and 24.3% programs were unfilled. And if you look at the breakdown of who is coming in, here is the breakdown. 56.7% MD graduates and 14.1% international medical graduates. I want you to pay attention to the fact that we have over 250, 275 positions that are filled, and we offer more than 300 positions, and we have more than 80 programs. So these two numbers are important when we think of creating a separate residency. And so I want you to pay attention to those two numbers. These are graphs from Twitter. So this talks about who is coming into pediatric residency. I briefly want to highlight the fact that in pediatrics, we have a substantial component of international medical graduates. This whole yellow thing over here is international medical graduates. With recent changes in immigration and with several universities reporting that students are not able to get their visas or visas are being rejected, this cohort of recruits might be brought into question, and we need to be aware of that fact that these people may not prefer to come to us from other countries. So there might be a risk of losing some of these residents coming into pediatrics. What about fellowship? As I mentioned previously, if you divide fellowship into different tiers, tier 1 is where you fill more than 90%, tier 2 between 80 and 90%. We have slipped away from tier 1 to tier 2. Interestingly, this year, critical care and hospital medicine are the two ones that we really compete with, and both of them did really well. And hospital medicine, especially in my opinion, is taking away quite a few of the fellows who are planning to join neonatology, and we are losing them to hospital medicine. This also turns out to be a relatively a shorter fellowship, to my knowledge, and I will talk about some financial differences between hospitalist medicine and neonatology in the subsequent slides. So if you look at the unfilled seats and look at different specialties, I often call these the reading subspecialties: rheumatology, endocrinology, adolescent medicine, child abuse, developmental behavioral pediatrics, infectious disease, nephrology, and genetics. These have not done traditionally well, and their percentage keeps going down year by year. And the one thing that was really shocking to me last year was nephrology fill rate of only 37%, which is really concerning. And I think it's a wake-up call for many pediatric subspecialists. But focusing on neonatology, although we have been increasing the number of slots, the increasing percentage of unfilled seats is concerning. It has gone up from 2.8% in 2021 to 6.9% in 2022, 11.3 in 2023, and 12.6 in 2024, rather. So this has been a fairly rapid progression, although this increase is mainly due to increasing slots. I think the number of positions that really filled were fairly constant. But what is really worrisome here is that these things are happening before the ACGME induced reduction in NICU rotations has been put in place. And starting this July, if we don't have access to pediatric residents, if there is no way for us to impress them to come to neonatology, if the amount of time we are spending with them is further reduced, it's going to further impact us in our ability to convince them to come into doing a neonatal fellowship. So to summarize the crisis, overall there is less interest in pediatric residency, and these residents will be spending less time in the NICU thanks to ACGME, and that will in turn lead to less number of fellows joining in. And given the crisis that's happening among the workforce, there are fewer and fewer inspiring role models. These are clinicians and physician scientists who can inspire residents to join neonatal fellowship, and that number is dwindling. There is also increased burnout and difficulties with work-life integration among neonatologists, and there is a large aging workforce that's contributing to reduction in the pediatric subspecialist workforce in general and neonatal workforce in particular. And so a combination of less role models plus less time in the NICU for residents will really create a crisis for us in recruiting people to come and join neonatal fellowship. Why is morale not that great in the NICU right now? Throughout the country, there has been a bit of a crisis in academic pediatrics. Part of the reason for that is that the distinction between academic or university affiliated neonatologists versus a non-university based or a private practice model neonatologist is slowly going away. When I was a initial attending in the 1990s, I could come and round for 2 or 3 hours and then go to my sheep lab or do whatever I wanted to do. And the fellows would take care of everything. And then I would come back in the evening for sign out. So those days are gone. And now the productivity benchmarks have gone up. Attendings are staying in-house at night call. There is a lot of hands-on care required by attendings. There is reduced access to trainees, and the stress of promotions and merits and focus on research, scholarly activity, and teaching has gone up. Many clinical neonatologists feel less recognition and less engagement, and this threat that everybody should be a triple threat is becoming quite a bit of an issue. And because of all this, there is reduced interest in academic or university affiliated neonatology. On the other hand, non-university based neonatologists have less productivity benchmarks, a lot more flexibility in their schedule, and given the fact that many of them have large access to large databases, for example, pediatrics and mednacs have access to their big database and they can come up with any JM publications. So this distinction between academic and non-academic neonatology is slowly dwindling away, contributing to more stress out and loss of engagement among academic neonatologists, with increased movement from academic group to the non-academic group. So if you look at data from the American Board of Pediatrics website, many of you, when you fill out your MOCA, when you take your MOCA PEDS exams, you do these surveys and they collect data from that. And I'm just comparing two specialties, pediatric critical care and neonatology. You would expect both of them to be really identical, but as you can see here, only 40.8% of neonatologists that take MOCA peds consider them to be full-time academic faculty. And this is in comparison to 35.5% who say no to being academic faculty. And compare similar numbers for pediatric critical care. It's 62.9% being full-time academic faculty. There's a huge difference between neonatology and pediatric critical care. The other specialty that is relatively economically quite positive is pediatric cardiology. And in that case, full-time academic percentage is around 65%. So we are an outlier in many ways, 62.9, 63 and 65% in PICU and cardiology, whereas only 41% of our neonatologists in this country are full-time academic faculty. So this transfer or shift from academic to non-academic neonatology is happening at a very high rate. So in addition to that, there are lots of areas where there is concern. If you look at the survey results from the ABP website, what you will notice is that neonatologists, there are a higher number of female fellows in neonatology compared to all the other specialties, excluding neonatology. And what is even more worrisome to me is that the percentage of time neonatologists spend in research is significantly lower compared to other subspecialties. For example, 3.8% of pediatric subspecialists other than neonatology spend more than or equal to 75% time in research, whereas that number is literally a third, 1.3% for neonatology. And you see similar reductions at every single level. So although we are a field that generally has a lot of productivity, our engagement in research has gradually gone down with time compared to other pediatric subspecialists. I already mentioned to you about the difference in full-time academics between non-neonatology pediatric subspecialists and neonatology pediatric subspecialists. So what is the economic and productivity argument for having a separate residency and possibly a separate department? These graphs are a little complex. I'll walk you through them slowly. So this is a graph of adult versus pediatric academic compensation versus productivity. So what it is that all these gray bars that you see is percentage of adult work RVU benchmarks. Those are the gray bars. The black bars are percentage of adult compensation. For example, gastroenterologists earn approximately 62% of an adult gastroenterologist in salary. That's the black bar over here. The light gray bar is that gastroenterologists produce approximately 58% of adult productivity or work RVUs. So you can clearly see that in gastroenterology, at least, pediatric gastroenterologists produce 62% of work RVUs.
We can record it, so maybe they'll send it out.
Hold on.
Okay. You can keep going. I muted them.
Yeah, okay, great. So in gastroenterology, you can see that their productivity as a percentage of adult productivity is on par with their salary as a percentage of their adult salary. And there are various reasons for it, and we can go into that in greater detail some other time. For example, for those of you who have been lucky enough to get a colonoscopy, you fully know that you go to an adult GI lab, it's almost like a factory. You go in and you come out, you go in and come out, and they can do it anywhere from 15 to 18 colonoscopies in a given day. On the other hand, when you go to a pediatric GI lab, it's very difficult to even get 3 to 4 cases done because these children are complex. Giving them anesthesia is a difficult thing. And so so the amount of productivity in pediatric GI is significantly lower. But what I want you to focus on is the fact that there's a clear-cut relationship between productivity and salary in pediatric gastroenterology compared to adult gastroenterology. So if you consider this to be 100%, the dark red line over here, you will see similar tendency in pediatric nephrology. For example, nephrologists generate around 43% of RVUs compared to an adult nephrologist, and their salary is around 80% of an adult nephrologist. So these things go hand in hand in most cases. On the other hand, if you go to a surgical field, for example, pediatric surgeons only generate somewhere close to 80% of the work RVUs of an adult surgeon, but their salary is 130% of that of an adult surgeon. So in surgeons, this principle does not apply. And the clear-cut outlier in this whole process is this one, And of course, that's neonatology. We generate close to 200% of adult pulmonary critical care work RVUs, but our salary is less than 80% of adult pulmonary critical care salary. So we clearly are an outlier among all pediatric subspecialties when you match productivity with salary. And the reason for that is that our benchmarks for productivity are sky high. There are two commonly used benchmarks for productivity. One is the AAAP, which is the Academic Pediatric Professionals Group, which is what most of our departments use. And here over the years, I have plotted where our work RVUs have been. And thankfully, I'm happy to report that these benchmarks have gradually come down more recently. And this is another benchmark called CPSC, which is a bit more aggressive in how it collects data. And so these numbers usually tend to be a bit higher. We use these at UC Davis. And so these numbers are slightly higher. And the good thing is that this year, both these numbers are fairly identical and they have come down. And the real numbers are over here. Please don't post any of these numbers on Twitter. This is confidential information, so don't do any social media stuff with these figures. So here are data from CPSC. And what is really fascinating here is the three inpatient pediatric subspecialties. In AAAP, pediatric hospitalists are supposed to produce, their benchmark is 2,775 work RVUs. Critical care is 5,271, whereas our benchmark is close to 10,000. In CPSC, very similar trend, although some numbers are slightly different because the N for both of these is a bit different, and CPSC traditionally includes moonlighting work reviews as well. So either way, the relationship is usually fairly linear. If pediatric hospitalists produce X number of work reviews, peds critical care produces 2X close to, and neonatology produces 3X number of work reviews. Although the difference in work reviews is quite similar, the salaries tend to not match quite a bit in that way. Here is a graph of all salaries of many subspecialties, both including medicine, including pediatrics and adult and surgical specialties. If you look at all the 128 specialties listed in AAMC, the least paid specialty is pediatric infectious disease, and the highest paid specialty is neurosurgery. And here is general internal medicine, and neonatology and critical care pediatrics are down here in the middle. So we are relatively better than many of the other pediatric subspecialties. Everything that's highlighted here in yellow is pediatrics. It's also concerning to see that the lowest paid 15 of the lowest paid specialties, more than 13 are all in pediatrics, and that's very concerning. It's very always highlighted that pediatric infectious disease folks make a lot, very low salaries, and which is really true, and I'm not questioning that. And we look relatively better, but this comparison should be looked at in a slightly different way, in my opinion. And anyhow, the highest paid one people are the neurosurgeons over here. What is very interesting to me is that these low salaries are limited to pediatric medical specialties only. For example, pediatric anesthesiology and pediatric surgery, they don't make less money compared to their adult counterparts. They either make the same amount of money in anesthesia or actually higher salaries in pediatric surgery. The second interesting fact is that when you look at a nurse or a nurse practitioner or a PA working in pediatric infectious disease versus an NICU versus pediatric surgery or neurosurgery, their salaries are all fairly similar. On the other hand, with MDs, with physicians, there's a huge, literally a five-fold variation in salary between peds infectious disease and neurosurgery. So these are quite a bit of discrepancy, and it becomes very difficult for a pediatric department chair to balance the books given these variations. So when you look at specialties that have more than 10,000 work RVU benchmark per year, I listed a few of those and their weighted rank salaries over here. As you can see here, of all the specialties that make more than 10,000 work RVUs, we are the ones that are lowest paid. This is an aggregate salary of all ranks plus moonlighting. So it's a bit of a higher number. But I want to show you the comparison between neonatology and neurosurgery. We have identical work RVU benchmarks, but our salaries are nothing but identical. This is a paper that Chris Bishop wrote recently on why academic neonatology why we should be concerned about academic neonatology, because the biggest reason I think of is that without having engaged academic neonatologists, it's very difficult to sustain fellowships and attract fellows to come into our division to be academic fellows after they graduate. So when you go to chair meetings, there is very little concern about what's happening to neonatology. The biggest concern is with outpatient pediatrics, and that's justifiably so because their fill rates are less than 50% for many of the fellowships. And these are the reading subspecialties that I was talking about. So along with a few chairs, we came up with an argument that no pediatric subspecialist should be paid less than a salary of a general pediatricians. Just so you guys are aware, there are 8 subspecialists whose salaries are significantly lower than Gen Peds. And so what we do in my department and several other departments now is what we call as raising the bar, where we increase all the salary for these specialties. For example, if a adolescent medicine specialist does not bring in enough money, we add money to bring the salary to that on par with that of a general pediatrician. And this has been a very effective strategy to recruit outpatient pediatric subspecialists. So what is the non-economic argument to have a separate residency and a separate department? We have pretty high needs in flexibility requirements. We need to be a lot more adaptive because the field of neonatology is rapidly changing, and the complexity of patients and the chronicity of patients in the NICU has increased quite a bit. And we need to be much more adaptable, and then we need to improvise with the changing times. When I did my fellowships, 22 and 23 weekers didn't exist. We were not resuscitating them, and now they form a huge component of the NICU. Cooling wasn't around. All these complex PPH and babies weren't around. So we need to improvise and adjust to the new environment. And it's also important to recognize hardworking clinical faculty and make sure that they play a really important role in recruiting and retaining fellows. So what are the solutions? What can we do to attract more trainees to neonatal fellowship? And there are 2 approaches here. One is either to have a residency in neonatology, and that's the paper that Brooke was referring to earlier. And the second option is to see if we should cut the duration of neonatal perinatal medicine fellowship to a 2-year fellowship. And this was a paper that many of the colleagues in the audience talked about, and was led by Shetal to write a paper as to whether a 2-year residency is an option. 2-year fellowship is an option. So currently we have a 3-year pediatric residency and a 3-year fellowship, a total of 6 years in training. And we were discussing as to whether a 3-year pediatric fellowship and a 3-year pediatric residency and a 2-year fellowship would be an option. The other approach would be to do a shorter pediatric residency and then followed by a neonatology residency or fellowship to a total of around 5 years. And all these are options that can be put on the table. Just so you know, the main factor that led us to have this discussion was the National Academies of Sciences in Engineering and Medicine, NASM report, suggesting as to whether the duration of fellowships can be reduced in pediatrics, similar to what's happening in the adult field, where literally half of the adult fellowships are only 2 years and not 3 years, which is very different from pediatrics. So that was the discussion. And this is a figure from the Shetal Shah's paper, and the bottom line was that 2-year fellowship is not the answer. And one of the main reasons being the fact that if residents are spending hardly a month or month and a half in the NICU, the incoming fellows require quite a bit of time to learn the basic procedures of intubation, chest tubes, lines, etc. And it does not make any sense to cut the duration of fellowship because the incoming fellows require a lot more training. So we felt that there were many other pros and cons, and you can go over these, but overall, this does not appear to be the right answer to reduce the duration of fellowship to attract more fellows to come in. Moreover, neonatology is getting more complex. We have hemodynamics, ECMO, transport, and QI, a lot of things to learn, and 2 years is not adequate to learn all this. So that brought about the discussion as to whether there should be a residency in neonatology and as to whether there should be a department of neonatal critical care. So this argument of either a 1 or 2-year PEDS residency, similar to what happens in pediatric neurology, followed by a neonatology, whatever you want to call it, residency, should be followed, either making it a total of 4 years or 5 years. Is that a better approach? So the way we were envisioning this, this was a paper with my mentor, Robin Steinhorn, who is the senior vice president at Rady Children's Health. The way we were envisioning is that if you think of yourself as a neonatologist and you attend all the pediatric grand rounds, think of the number of grand rounds that really make sense to you. It's probably like 10% of pediatric grand rounds. On the other hand, if you hear lectures happening in maternal fetal medicine, those things are make a lot more sense to you than the lectures you hear at pediatric grand rounds. So we wanted to create a, a neonatal critical care department and possibly a MFM department in conjunction with the departments of pediatrics and OBGYN. And within the neonatal critical care department, you will have different divisions, like the general NICU division, specialized NICU divisions, which include small baby units, neuro NICU, cardiac NICU, BPD, surgical unit, etc. And then have a newborn nursery as a division as well, and this nursery is managed by neonatal hospitalists. And you run a fetal consult service in conjunction with MFM, and you work closely with pediatrics to create a follow-up clinic. So instead of having a pediatric residency and a neonatal fellowship here, you move into a situation where you have a shorter pediatric residency, similar to neurology, and then you follow this up with a 3-year fellowship in neonatology, or if need be, a slightly longer one. So this can be discussed further, and this gives the fellows or residents in neonatology adequate time to develop some expertise in research, QI, transport, POCUS, hemodynamics and TN echo, focus more on whatever area that they want to focus on and get more expertise in that area. So how do we go about doing it? If in general, if it's felt that this is the right approach to do, we need some approval from these 3 agencies, the American Board of Pediatrics, the American Academy of Pediatrics, and the ACGME. Assuming that ONTPD leadership is on board with at least thinking about this idea. So what does this look like? In my opinion, the step 1 is to reach out to ABP. I have presented and forwarded some of these papers to both Dr. Barone and Dr. Woods in the past. And this topic has come up at the neonatal sub-board meeting briefly. And I think it's worthwhile reaching out to them and talking to them to see whether they would consider something like this. The biggest pro for such an argument is that compared to pediatric neurology, where very few pediatric neurologists maintain pediatric certification, and actually their certification comes from the neurology board, both pediatrics and neonatology will be part of ABP. So financially, ABP does not lose out on anything. So we are all still in the same board. And if necessary, both pathways might exist, a traditional neonatology fellowship pathway and a residency in neonatology, and they will all take the same neonatal sub-boards or whatever you want to call it. So this is one approach to work with ABP and see if they're willing to consider this approach. The second obviously would be to reach out to AAP leadership. Dr. Clara Song is who is our chair of the society right now. She is aware of this paper and we can reach out to her for help. And then we can meet with the AAP president and AAP CEO and see if they're on board. At least I was told that the AAP CEO, Mark Del Monte, is at least aware of this paper. And so it will not be a big surprise to them. If there is support from them, that would be great to move ahead with this. If there is no support, there should always be a discussion as to whether we need another agency which is advanced, like an American Academy of Neonatology or something else that's our own to discuss these issues. But I don't think it will come to that. Then the bigger step is to work with ACGME. If you go to the website I was indicating in a previous slide, there are clear-cut criteria as to what is required to create a new specialty, although I don't know if you are considered a new specialty or just a redesignation. So to create a new specialty, there are all these criteria demonstrate that clinical care of patients and safety will be improved through accreditation, designation, etc., which is true in my opinion, represents a new and well-defined field in medical practice, which I believe is totally true. Based on substantial advancement in medical science, that is true. And if you keep going into this, at a minimum maintains at least 50 active programs and 200 residents annually nationally. And we have 81 active programs, I believe, and close to 300 fellows per year. So we do meet all the requirements that are necessary to create a active residency program in neonatology. If neurosurgery and pediatric neurology can have their own residency, why can't we, is my question. And the number of neurosurgeons in this country is much lower than the number of neonatologists, and yet they have separate departments, separate residencies, etc. And as I mentioned to you previously, the number of work RVUs that a neonatologist produces is on par with the work RVUs produced by a neurosurgeon. The challenges, there are several challenges to this. The visibility of neonatal critical care in medical school is not that great. We need to do something to make sure students are aware of this specialty and are willing to consider this. They need to have rotations, or we need to somehow increase visibility among students so that just after finishing medical school, they will be willing to consider a residency in neonatology. And there is a possibility that there will be considerable opposition from other pediatric subspecialists and possibly chairs in creating a separate residency. And that issue needs to be addressed. And what will happen to the pediatric residency recruitment? I'm hoping that people who want to go into pediatrics will continue to go into pediatrics at the same number, and an additional pool of medical students will come and join neonatology. So the net number of students entering into the pediatric workforce will actually go up with this, is my hope. But one other possibility is that there should be two pathways. One, either you can join a neonatology residency straight after medical school and do it for 5 years, or if you can make up your mind, you can join pediatric residency, and then you should be able to hop back into the traditional path and join in a neonatology fellowship. And both should be an option, in my opinion. So I will stop here, and if there is interest and time, we can talk about the impact of a separate department and financial implications a little later. So let me stop there and check the chat. Oh, wow, there's a lot of chat. Great. Oh,
there's a lot of questions that I've been searching through, but I think the primary one, like one of the first ones that comes to mind, is that maybe the 2-year fellowship doesn't work in the current model of a third clinical and 2/3 research, but what about a more clinical heavy? And do we actually need to be thinking about that no matter what we do, due to the less experience, that maybe a third clinical is not enough with the lower experience, even in a 3-year fellowship?
Yeah, to be honest, when we started writing the paper that Shetal led, Patrick and others will tell you that I was very much I was probably the only person in favor of a 2-year fellowship. There was a considerable concern that the incoming fellows would be very much green and require a lot of support. And for that reason, if they're taking 6 months to a year in the first year, needing to fine-tune their skills in basic neonatology, they don't have enough time to graduate. And even for those going into private practice, it was felt that they will need skills in QI or other areas, and they will not be able to take on or complete a fellowship within 2 years. That was the general feeling. I would have listened to your argument, Brooke, if it didn't have this ACGME imposed restriction in the time they spend in the NICU. With the new guidelines suggesting that even 4 weeks is adequate, I think it becomes pretty challenging to finish a neonatal fellowship in a period less than 3 years. So Anne-Marie is saying about, in recent years, NNPs have been the highest paid of all NPs. Yes, that is true. And there is a significant variation in geographic location as well. On the West Coast, their salaries are pretty high, on par, if not higher than a new faculty member. And Patrick comments that at Iowa, with programs such as hemodynamics, neurocritical care, and lung care, BPD, the number of consults and subspecialists is much less. Yeah, that's an important aspect as well. So if we become less and less dependent on other consultants, then that should be another way of looking at it.
I think somebody also is making the comment of this neonatal residency and the idea of having some general pediatrics, kind of taking the surgery model of you know, you do an intern year and then you go to your specialty like ENT or urology. But also thinking about then taking some of these other more advanced neonatology things such as POCUS and what are some other things? Echo, ROP, ECMO, and making those fellowship 1 year non-ACGME fellowships after is also an idea if you have that extra year, because now you're down to 5 years or 4 years.
Yeah, given the discrepancy between a faculty or a neonatologist's salary versus a stipend you get as a fellow, the inclination for doing 1 more year of fellowship is a little less. But yes, there are dedicated people who do fellowship in hemodynamics or one of those areas. I do agree with you. That's definitely an option. Wow, there's lots of questions here. It might be easy if people unmute and ask them.
Yeah, if anybody wants to unmute, go ahead, or at least raise your hand and I can unmute you. Is that possible for people to do?
There are lots
Oh,
of.
here's a hand. All right, here we go. Deanne Pillars has a question. Go ahead, Deanne.
Hi, I put it in the chat as well. I think we're all feeling some of these frustrations, and we're working harder and harder and getting less for it, and seeing other groups having the advantage of our labor and their academic success, etc. So I'm intrigued by the concept of being freestanding. I have also heard of one step shy of being a department, which is being a freestanding division within the College of Medicine. But I worry, where do we get the funds to pay, for example, central administration in the department, for the HR that we need, or the research administration? And I'm curious, I know there's some people on here who are in freestanding departments of neonatology, and I wonder if they could give us some insight into how that all works.
Those are great questions, Deanne. I have one more section of the talk, and one of those topics is that if neonatology is allowed to retain all its funds within the division or the department or however you want to call it, and not give out any fee collections, professional fee collections, you can easily afford paying out central administrators, etc. There are folks here. I mean, Dr. Terry Inder is here. I believe, Terry, you had a.
I'm happy to speak to this.
Yeah, please. Yeah.
So I was recruited to the Brigham at the time. It was an independently created freestanding department of newborn medicine. And there were huge advantages to that, right? We could focus on our mission. We could recruit faculty. We had quite a significant funds flow that allowed us to dedicate opportunities for research. We had funds flow for administration. We were financially extremely stable. Having said that, we are no longer an independent department. We have now been absorbed into a new merged structure with Mass General Brigham, where we are now back to being a division under the Department of Pediatrics, which is a Mass General Brigham. And as mergers increasingly occur across systems, then having freestanding departments, or many of them, that aren't either merged in some way or becoming integrated into larger integrated service or clinical lines. And some people are talking about neonatology being integrated with obstetrics as part of a perinatal clinical service line. My concern about all of those things is the academic mission. And I would love Satyan to speak to that, because one of the things we lacked and I had difficulty advocating for was how to integrate subspecialty medicine in an optimal way, because we were seen as a separate group. It was always a collaborative negotiation. Particularly for us, it was either with Mass General or Boston Children's, but But when you are outside the group and you've done it for what some people have seen to be your own financial benefit, it can be difficult to then go to the well and ask groups that are struggling to assist you in the mission of either discovery or innovation or things that are not financially positive gains for any group of physicians. And I think that's where we share the gain, we share the pain mentality can come in. And we are fortunate in neonatology to have a very large revenue stream from the way our RVUs are assigned. And that's not something that the people who are working in areas where RVUs are not well assigned, like developmental pediatrics, could control. And so there's some sharing of the responsibility when you are within a larger group. Having said that, is there a middle ground, which I think would be wonderful to be able to aspire. So the two issues are very separate, I think, the issue of the training pathway and the issue of the systems administration to be both a member of a community that has joint responsibility and accountability, but also joint opportunities. And I would, as I say, love Satyan to just reflect on that from an academic point of view. But my experience was very short-lived because the department itself existed for 10 years and now has been absorbed into the Department of Pediatrics.
Terry, those are great comments, and I really appreciate your input. The bottom line from my perspective is that let's go back 20 years. There are lots of seniors here. Christy is here. Let's go back 20 years and let's assume that neonatology was not there to bail out the rest of the divisions. What would have happened then? What would have happened then is that all the divisions would have lobbied and had undergone policy changes to become self-sustainable. The very fact that neonatology was subsidizing these divisions has led to this situation where the reimbursement is woefully inadequate for hardworking specialists in developmental behavioral pediatrics and genetics, and that's not the right thing to do. But the solution should not be based on neonatology. The solution has to come within that division itself, and so that's my argument. And if there is like 5 minutes time at the end, I want to show some slides on the fact that funds flow, which is being increasingly adopted by many departments and many schools of medicine, has leveled the playing field. And at least in my department, we don't have any rich divisions or poor divisions. For example, developmental behavioral pediatrics makes as much profit as neonatology does because the funding is completely altered. And so with increased use of these models, that dependency between neonatology and other dependency of other divisions on neonatology is gradually going away. And once people perceive that this relationship doesn't exist anymore, then we always collaborate with, we collaborate with MFM folks, we collaborate with physiologists, many other departments, and collaboration between the rest of pediatrics and neonatology will be fairly similar. Brooke, if I have 5 minutes at the end, I'll show you how the funds flow model works and show that.
Yeah, two more people have their hands raised. Patrick Myers, you can go ahead and speak.
Hey, Patrick.
Hey, Satyan. Thank you, Brooke. So a quick comment and then a question. I think ONTPD is going to talk about this at PAS. So for people in the audience, will be more opportunities, both virtually and live. My guess is we will also chat about it at NCE. It would be interesting to hear what the academic section chiefs as a group think about it as well, and it may be worth us having a joint discussion at some point. Satyan, have you thought about actually not rearranging neonatology, but rather rearranging pediatric residency? I think actually the split is most acute between the hospitalist-based subspecialties and the reading specialties. And is there an opportunity, and it may be more palatable, to have, internship, and then you decide to do 2 years of hospitalist-based pediatric residency, and then you can move on to CARDS, hospitalist-based medicine, PEM, NICU, PICU, or you do internship and then 2 years of reading elective, and then we could perhaps shorten the fellowship to 2 years. So I think that there are creative ways to reconfigure both peds and neonatology globally Because if you look at the ACGME's recs for the last 2 cycles, and we're, what, 5 years away from another cycle at this point, that seems to be the most challenging part to me. Thank you.
No, that's a great comment, Patrick. The challenge there is that hospitalist medicine is a very interesting field. Let me just show you a couple slides and then we'll skip back. The part I was referring to is with funds flow is this. When you enter into a funds flow arrangement, the payment shifts to what is called as a dollar per work RPU, where they take into account your benchmark salary and divide that by your benchmark work RVUs. So the amount you get per work RVU changes quite a bit between divisions. This is my departmental average. We get $62 per RVU on an average, but look at the differences. In ID, genomics, hospitalist medicine, they make somewhere close to $90, whereas neonatology gets close to $30. So funds flow tends to equalize everything else, and so it's a little complex, but your approach for training is definitely a valid one and can be looked into.
Right. Dr. Singh, I think
Yeah,
you
hi,
can go ahead.
everyone. Satyan, that's a great conversation that you initiated here. I can see a lot of challenge for the departments that are not within a children's standing hospital, because I can see our chair totally revolting if we decided to break away, because then there would be a lot of complaints from the subsequent division. So I'm not going to talk much about that yet. But for the training
Can
purpose,
I interrupt you for a second there?
yeah.
I actually think it's the other way around. I think in institutions that are not freestanding children's hospitals, it's much easier for neonatology to align with MFM and other specialties to create something separate from pediatrics. It's much more difficult in freestanding hospitals from my perspective, but I might be wrong here, but that's the way I see it.
Well, currently we are supporting all the divisions. I totally then do not see a Department of Pediatrics being able to stand by itself with the way the RVUs and all flow. And at least that's my understanding from having spoken to our chair. But I was trying to focus more on the educational aspect of it. You know, you've made a great point that the academic mentor numbers is dwindling down. But the number of trainees who still need to do those scholarly projects because ACGME mandates that they have to do research, and then you're trying to pull through or spread your time in trying to get everybody be able to do something that is then quote unquote publishable, which then brings the quality of research that happens. I mean, some of the articles that I read, I'm like, do we really need to do this one more time? I'd rather use my energy for something more cutting edge for research. So maybe one of the simplest or the low hanging fruit would be just to have a 2-year fellowship for clinically geared people, where they mostly spend their time doing the clinical work, and then have a 3-year fellowship for people who really are into research, really want to take that as a career going forward, because then you can invest more time into it. And as far as there was some question about medical students coming in with our closure of pediatric residency, we see consistent medical students coming to us and totally enjoy being within the NICU. So that has been a big plus. We recently had somebody who rotated with us and said, this confirms the reason why I want to go into pediatrics, which was very heartening. So with that, I'll
Yeah,
go.
no, the arguments you make are very valid. I'm happy to hear that a lot more students are interested in neonatology, which is good. With regards to the argument about having a clinical fellowship and a more research-oriented 3-year fellowship, I'm a classic example of someone who walked into neonatology fully intending to be a clinical neonatologist with absolutely zero interest in research till I met Robin Steinhorn, and my life changed after that. So there are people like me who were forced to do research, and then we realized that we really enjoy it and started doing more research. So that particular pipeline of physician scientists will be lost if we follow a 2-year path. That's one concern. But it's definitely an option. So all options are on the table, and I'm not saying that we should follow one particular path, but there are, in my opinion, there are specific advantages to calling it a residency and keeping it a bit separate, like surgical fields, compared to doing a shorter fellowship. Had we not come up with this 12-week inpatient, 4-week minimum neonatology rule from ACGME, I would be much more gung-ho on a 2-year fellowship. But given that rule, I'm really worried that incoming fellows require quite a bit of time to learn basic neonatal techniques. Heather?
Dr. French has her hand raised. Go ahead.
Hi, Satyan. Thanks so much for your talk. My question is more like, it's going back earlier, back to medical school. This isn't about financing, but really, I love the idea of 5 years of training. I have so many ARP trainees in our program who have done 2 years of residency and then gone on to fellowship, and they do amazing. They're wonderful trainees. But I'm wondering if, as we move, it's, as the potential to move forward with 2 years of residency, how do we get more pediatric exposure at the medical school level? Like, this is a pathway problem for all of us. I had put in the chat just, if 25% of the lifespan is pediatric, but we get 10%, maybe 15% of the billing during core clerkships, it seems like we really need to be advocating, back at the LCME to improve pediatric exposure during medical school, so that we do get more interested candidates into, pediatrics, and they actually have an opportunity to be exposed to NICU in medical school. So I'm wondering if discussions like, on this topic have been occurring at the chief department chair level, and how we can start lobbying the LCME.
That's a great question, Heather. The short answer is that approach has not been discussed. The difference I notice is that in the past, if you had told this to me 10 years ago, I'd have probably agreed with you 100%. But the new batch of students are very savvy. Honestly, nobody had ever asked me what would be the salary of a pediatrician, a medical student, had never asked me that question until COVID happened. And now they openly ask me, what will I make if I become a neonatologist? What will I make if I become a PEDS ID person? And the moment they hear it, they will jump and go into pediatric anesthesia. You have no idea how many of my student mentees have quit pediatric residency, have gone into PEDS anesthesia or PEDS, some other PEDS ENT or something like that. So compensation does play a very significant role here. But I do agree with you that increasing exposure won't hurt. We can either go with the amount of time you spend in a lifespan, or the percentage of children in this country. Even that number is higher than 15%. So we can use that argument to say how much time they should spend in pediatrics. Both are very effective arguments. But without addressing the issue of compensation, it will be very difficult to convince the current generation. A student sitting with a $300,000 debt will want to clear that fast, rather than, I think that would be a big priority. Having a loan repayment program somehow uniquely tailored to pediatrics will work, but we need more innovative solutions like that to address this. But either way, spending more time in pediatrics is a good one, and I can bring it up at a future AMSTAC meeting, but it has not been on the forefront, at least that I know of.
We have 3 minutes left. Do you want to show those last few slides?
Oh boy, okay.
You can have an extra 2 minutes if our
Okay.
webinar doesn't cut off.
Okay, so we talked about dollar per work hour view. So I just want to show some differences between internal medicine and pediatrics as to what people often compare the two departments and say, oh, they can do it, why can't you do it? So this is a work hour view comparison in internal medicine. I did include genetics because some adult internal medicine have genetics, but if you exclude palliative care and genetics, which are kind of slightly different, geriatrics has the lowest productivity in internal medicine, and the cardiac electrophysiology has the highest productivity. And this range is from 4,000 to somewhere close to 11,500. That's the range that you spend in internal medicine, whereas the range in pediatrics is 2,000 to 10,500. So the range is much wider in pediatrics. But what is even more important is that there is salary variation here. The relationship between the productivity and salary is linear in internal medicine. So when you do the dollar per work hour view calculations, if you exclude nephrology, which is a bit of an outlier, and we can talk about it later, the range is fair. I mean, it's not a huge range. It ranges from $50 to $80, and it's not as discrepant as what you see in pediatrics. So anyway, you see neonatology is an outlier in pediatrics. When you combine both internal medicine and pediatrics as a single entity and you compare all these specialties, And for that reason, more and more health systems have gone into what is called as funds flow. So in funds flow, if you can consider this to be the collections-based traditional funds flow model, you bill for your patient. If it's Medicaid, you collect so many work RVUs. Commercial, you collect so many work RVUs. You get less payment for Medicaid, more payment for commercial. All this money comes to the department. You to take all these collections and then you use this to pay off salaries, etc. You deal with denials, etc. This is a classic collection-based model where we all were in. But increasingly, we are moving into a productivity-based model, which includes just all the money goes into the health system, but then they look at the RVUs that you produce, and you don't have to worry as to whether you're seeing Medicaid or commercial. And then you, based on the RVUs you generate, the hospital or the health system pays you salaries. The other one that's more common in neonatology is the staffing model, where they consider total hours per work year, and then they look at how many FTEs you need and multiply those two and pay you the money for X number of FTEs. The thing I want to point out, especially for division chiefs here, is that both of these models, the productivity model and the staffing model, are hugely disadvantageous for neonatology. See here, if you look at the productivity to total compensation ratio, then this green line is 1. Neonatology is a huge exception. And when you convert from traditional collection-based model, which is the red bars here, to funds flow model, which is the green bar here, pretty much everybody does relatively okay, except cardiology, PICU, and neonatology loses out a lot. So the advantage of using funds flow is that other divisions are no longer dependent on neonatology. So this is the guilt that Terry was talking about. You don't have to have this guilt that you abandoned the rest of the group. But at the same token, there's a drastic reduction in divisional income in productivity and staffing models for neonatology. So this tends to work out a little differently. So I think I'll stop here just to introduce the concept of funds flow and the fact that with more and more institutions adopting that method, the dependence on neonatology will gradually go away. And this is not just an economic argument, but a culture argument that the culture within NICUs is so different from the rest of the specialties that having some clear-cut definitions.
Satyan, thank you so, so much. This was so appreciated. I know from the ONTPD community that I helped arrange this for, but I think there's a lot of division directors on this as well and other interested parties. So thank you so much for being here today. I'm sure he is willing to accept other questions through email, but please email me if you have further questions. And I know this is going to be a hot topic at PAS. We are going to be having for the ONTPD part, we're going to have an online, which I'll be leading, and the in-person people will be leading something in person at PAS.
Great. Thank you, Brooke, for the opportunity. My only request is don't get me into trouble with your chairs. I need to still survive at Amstack as a chair, so don't get me into trouble, please. And if somebody can collect the chat, hi, Misty, nice to see you. I'm happy to collect it and answer them.
Deidre, do you know how to collect the chat?
Yeah, I'll be able to do that. And
Okay.
The link will also be available. We'll keep it a private link, but I'll make sure that the division directors and ONTPD members all get that.
Thanks, everyone. Have a great day.
Thank you.
Really appreciate the opportunity.
Thank you so much.
Nice to see all of you.
Thank you.